Before I became a consultant, I was still trying to find myself. I was, a single mom with 2 children at that time. And their father had walked out the door and had said that he wanted to be married to somebody who was way more successful than I was. But, I just was barely getting by. It was a very difficult time. I can remember looking out in my front yard, and if the meter guy was he crossing to check the meter, or was he crossing my front yard to turn the electricity off? And even I can remember collecting our pop bottles and going in and, getting a nickel back. But every nickel, every penny, everything counted at that time. It took everything that I had to get through those times. I believed that I could get through anything.
Do you believe that you were put on this earth to do this?
Absolutely. I really, yes, because of all the fight. And I'm grateful, when people thought negative thoughts about what I did and who I was, I'm so grateful that I broke through those barriers and that there is this acceptance now. And I'm seeing it more and more so. And this is why I believe that the women who are out there selling this product have to continue to fight the fight. Because if not, when it comes to women's health, sexual health, it's going to be placed on the back burner. So bringing this to the forefront and demanding that we know our bodies better and that we can make decisions in our bedroom about what happens, that we have every right to do that, because not every single person could do what we do. It takes a very special person. It takes a person who has to break through barriers and has to stand up to naysayers. And they have to feel that in their heart that they were here, they were meant to do what they're doing. I know my consultants every single day face naysayers. And I love naysayers now. In the beginning, I think I just turned a deaf ear. I didn't listen to them. I had the battle with my own mother, who felt like, don't tell anybody you do this. Breaking barriers like that for me each and every day, and even in this city still, it gives me pride.
Founder of Pure Romance, Patty Brisben. Patty Brisben. Patty Brisben. Patty Brisben. Patty Brisben.
Dear Patty, how are you?
There were people who tried very hard and very diligently every single day to put me out of business.
Would it be to you and yours? Salutations to all. You can call me Cuddy or a mystery extravagant, cause I'm getting my money when my doors are swinging. It's like a bird on wheels. You can come to Ohio and you can see how it feels. You can come to Ohio and you can see how it feels.
So many women have been told early on, good girls don't do this. This isn't about a good girl. This just has nothing to do with that. This has to do with our bodies and ourselves and being able to effectively communicate with our significant other. The reason that we are so successful at what we do is because we're educators first. You've got to constantly educate yourself, and you've got to constantly have that backbone to know that you're doing the right thing, that you're supporting women, that you believe that women should have these choices.
No, you'll never find shit like mine, cause I provide that new. That new. I do. That new.
Ladies, are you ready to get your alert on this morning? What better reason to get out of bed bright and early to talk about such an important topic that is near and dear to all of our hearts? It is my absolute distinct pleasure and honor to bring to the stage your founder and the woman who absolutely started it all and blazed the trail. Give it up for your founder, Patty Brisben.
Good morning! Good morning, ladies. Thank you. What a way to start the morning. Look at all these beautiful faces. Oh my God. Thank you. And you know what? I couldn't think of a better way to spend my birthday than with all of you and the wonderful doctors that I'm getting ready to bring on stage. But before we do that, did everybody have an amazing night last night? Were you so surprised with Chingy showing up? Just a little something for you girls. So you're right, it is my birthday, and I couldn't think of a better way to spend it than talking about something that I'm so passionate about, and that is sexual health. So I'm so proud of this. I'm so proud that we're able to bring our sexual health panelists up here, our unbelievable therapists and physicians. And so I would love to welcome them to the stage right now. So give them a big round. Give them a pure romance round. Let's get started. So, as you know, I could not have the Sexual Health Matters series without these wonderful physicians that help me every single day. And every one of these physicians and therapists sit on our board at the Patty Brisben Foundation. So I'm grateful and thankful, and I feel so blessed to be in your presence. So thank you so much. So let's get this started. So the first person that I'd like to introduce you to today is Dr. Janelle Evans. She's a urogynecologist with Kettering Health Network. So, Dr. Evans, could you tell us exactly what a urogynecologist is?
Yeah. So the formal definition of urogynecologist is a big mouthful. It's female pelvic medicine and reconstructive surgery, which is basically just a big fancy word for I deal with everything from pelvic floor disorders, prolapse, incontinence, and everything in between.
Thank you. Dr. Sarah Bartlett is a gynecologist with Dr. Somi Javid and Associates, whose practice focuses on sexual health. Dr. Bartlett, how does this make you different from a typical OB/GYN?
So I am a gynecologist. I do all of the traditional gynecologic stuff. The difference is, once my patients become pregnant, I send them to an obstetrician for the actual pregnancy care and delivery, and then they come back to me afterwards. What that allows is we have a little bit different focus within our practice. We can spend more time at each office visit. We can keep the office smaller and keep it contained in a way that it feels very intimate. I tell people we have 6 chairs in the waiting room, and that is by design. I don't ever want 20 angry people waiting on me. And that environment lends itself to intimate, complex things like sexual health. So it has slowly become more of a focus because it's something we aggressively talk about and want to fix.
Dr. Kathleen Novicki is a pioneer in pelvic floor physical therapy in the greater Cincinnati area and practice at the Center for Pelvic Floor and Core Rehabilitation at the Oxford Physical Therapy. A lot of women, and I have to say this, and doctors, are not sure what a pelvic floor therapist is. Could you explain to our amazing consultants out here exactly what you do?
Yes, I'm very excited to be here. I've been doing this 30 years, but every day a woman comes to me and said they've never heard of pelvic floor physical therapy. So I'm hoping that today, as I explain some of the things that we do, it's specific through the lifespan, that it'll allay some of your anxiety as well as your client's anxiety so that people can get the help they need. We're not very different than traditional physical therapy, where you might go to improve how your knee or your shoulder functions after injury. But obviously we are dealing with the pelvic floor. So you're not going to be coming to me sitting in a large gym next to somebody with an ankle injury telling me about your bladder and bowel function. You'll be seen in a private room, and we definitely take your modesty and privacy in concern.
Thank you. Emma Schmidt is a certified sex therapist with Emma Schmidt and Associates, Sex and Relationship Therapy, the only sex therapy group practiced in Cincinnati. This is another profession that is really misunderstood. Could you tell everybody exactly what a sex therapist is and does?
Yeah. So I don't have sex with you, and I don't want you to have sex. That was back in the Masters and Johnson and Alfred Kinsey time. What I do is I do talk therapy. So I sit with a couple, I sit with an individual with relationships, and I guide you through any type of sexual struggle you're going through, whether that's infertility, sexual pain, wanting to work on spicing up your relationship, erectile dysfunction. If you're struggling with a sexual concern, I am there to help guide you to where you're wanting to go through a talk therapy type of modality. And then I provide you with exercises to go home and utilize. Sometimes that is through going to a pelvic floor therapist or seeing a sex medicine doctor or urogynecologist, coming back, us doing and processing the more emotional relationship part as well.
Thank you. Okay, we're going to start off this morning with reproductive age. And we're going to be talking about sexual health of women who are childbearing age. Dr. Bartlett, a lot of our consultants have clients that speak about the aftermath of pregnancy and childbirth. What are some of the sexual health challenges that these patients face?
It's kind of a big topic because there's different issues while pregnant as well as while undergoing infertility treatments, immediately postpartum, and then also while breastfeeding you continue to have challenges. Some of these challenges are hormonal across that spectrum. Some of them are physical. So we talk about things like changes in libido, which the other girls can talk about a little bit more, and how to keep that alive despite these hormone changes. The physical aspect is a really big one, and a lot of people like to focus on the immediate postpartum. And I want to begin by saying that a lot of women have normal deliveries, and after a short period of recovery, their bodies bounce back pretty okay. They return to normal sexual function. That is appropriate and common. That's not always the case, and it sort of depends on whether they have a C-section or if they have a traumatic vaginal birth, so something that required a lot of stitches, maybe forceps. Even those patients oftentimes return to normal. It just might require time and maybe pelvic floor physical therapy, maybe some other physical therapy type techniques. Specifically, we get a lot of questions about incontinence and prolapse, and oftentimes those are issues that maybe don't happen in young women until they've had a baby, and suddenly it may be pronounced postpartum, and a lot of times that is limited to that immediate postpartum time because there's people who are experts at that and can really help address it. But I try to remind people that the hormone changes, the physical changes, many of them, if not most of them, are temporary. You just need to talk to your doctor about which treatments can help expedite the healing.
Amazing. Dr. Novicki, as a pelvic floor physical therapist, are there specific tools that you can use to address the pelvic floor defects and pain post-childbirth for these patients? And are there products that our consultants can recommend?
Absolutely. I'm always excited when my patients come to me and they tell me they have a pure romance consultant, because we are there to help them know what they're doing is correct, but they have a lot of home treatment program and exercise program that they have to do. And if they have a consultant, as you're going to be able to help them choose the right tools so that they can be successful in continuing to do what they need to do at home. One of the things, of course, that we need to work on postpartum is improving strength. The muscles of the abdominal area, the hips, the pelvic floor, it gets stretched more than it's ever been stretched before. It may be torn, it may have had a surgical incision. So we want to return that strength back to normal. Not only for exercise and activities, but also in order so that they can help to support the function of your bowel, your bladder, and sexual function too. So of your products that you have to your disposal, you have the exerciser balls, and then you also have the Benoit balls too. What's nice about this is that they provide a level of awareness of where these muscles are. They're kind of hidden away. You can't see them. But if you place this in the vagina, it allows that muscle to know, am I using the right muscle or not? The other thing is that they're progressively weighted. You know, you start out with some that are 22 and go up to 40. And that's the concept of strengthening. You go from, if you wanted to strengthen your biceps, you'd go from 1 pound to 5 pounds. Well, you kind of are doing that too with the balls. Another thing that we do with women postpartum might be in dealing with the scar. If there's an episiotomy scar, or if there's post-tearing or a C-section scar, we want that scar to be flexible and elastic. So the things that work out really well for that, which we recommend, is the fractionated coconut oil and the Euphoria shea butter. That will help them to do some of the myofascial release techniques that we will show them to loosen up that scar, and it makes it pliable and no longer causes pain. You might have spasm around that scar. That's natural. Anytime that there's trauma, the body naturally goes into spasm to protect the area. And you can use the vibrators, and it can be either the penile vibrators or the clitoral vibrators. And you can see that if you just place that around the scar initially on a very gentle vibration, it provides a bit of myofascial release at home that they can do to help progress them along. And then eventually, as they feel comfortable, and we'll talk about this more later, they can use the dilator set, but I'll talk about that later.
Thank you. Emma, childbirth is a huge change for women, physically and emotionally. Many women, they silently struggle with this transition. What do you tell your patients?
Yeah, so first off, after childbirth, you were never meant to do this alone. And I think a lot of women think and feel like to be superhuman, to be what American society say we should do this on our own. And Emily Nagoski just came out with this new book called Burnout, and she is defining this term called the human giver syndrome. And what she says is when we as women are, as babies, we're born into a society here in America that says unless we're giving our all, we're failing. Unless we're giving everything of ourselves to everybody else, then we're failing. And to ask for anything for ourselves means that we're selfish and that we're asking for too much. And so what we find is then we give birth and we think, oh, I should still go into that place. I should still be in that space of, I need to give my all to my baby, to my family, around the house, to my partner, to my work, and we're completely drained, we're completely burnt out, right? And so what you need to know is that it's important to ask for help. It's important to ask your partner, hey, while I'm nursing, can you get me a pillow so that my arm isn't so so much in pain, or hey, can you ask our community to bring over some food, or if someone's asking, hey, can I just come and pick up? Whatever is helpful, be able to say yes. Surrender to that, ask for help, allow your community to be there for you, because you were never meant to do this alone, right? There's one part of our brain called the amygdala. And what happens when we're pregnant is that little part of our brain starts to open up. And that part of our brain opens up, its function is for worry, for depression, for anxiety. And the reason why that grows is because it allows us to be more in tune with the needs of our baby. It helps us be more alert to taking care of our child whenever we give birth. We're not used to being in that space, so our brain literally opens that space up so that we can take care of our baby in a more productive way. But what happens is then we're more prone to postpartum depression and postpartum anxiety, and we don't know why we're experiencing that. And it's because that amygdala has opened up a little bit more so that we're able to care for our child. So when you're experiencing postpartum anxiety, postpartum depression, being able to talk to your partner, being able to reach out for help, for community to talk about these things, remember knowing that you were never meant to do this alone. How can I reach out knowing that other people are experiencing this too, and that it's actually my brain opening up to be able to take care of my child. The other piece, like physically, that we see is say you're nursing. We get all these chemicals that flow through our body. If we're nursing, oxytocin starts to come. It's what we call the cuddling hormone. You might experience this after you have an orgasm, you want to cuddle with your partner. Well, the same thing happens when you nurse. So we get overwhelmed with just being really attached and in tune with our baby. What happens there is that means that we become more of a caretaker than we do a sexual partner. That part of our brain and that flood of oxytocin with our baby then takes away potentially that oxytocin that we have with our partner. We feel more of like a caretaker because our baby is here and that oxytocin is being attached to our child than it is to our partner. So how do I have these conversations with that partner? How do I have a conversation with myself about, okay, this is what I'm experiencing. How do I let go of what I thought postpartum would look like, that I thought it was going to be, my house was going to look Instagram worthy and that my baby would be amazing, and now I'm realizing I haven't showered in 3 days and my baby doesn't stop crying and I feel like I'm going to lose it. How do I start to let go of that part that I thought life was going to look like, and how do I start to adapt to this is my life, this is okay? How do I talk to my partner about, now that we're in this new transition of having a baby, what does life really look like and what do I need from you? What do I need for myself? Physically, there might be pain that's happening. You might experience body image difficulties. You thought your body would look one way, it looks like something else. Our breasts were growing and now they're sagging all of a sudden. What's happening there with childbirth, after childbirth? So there's a lot of body image stuff. How do I start to do some body acceptance? How do I start to be appreciative for what my body has done and gone through? It's been amazing what it just created, right? Getting back into sex, though, getting back into intimacy can be really challenging. I remember after my first child, thought of having sex, literally, I would gag in the shower thinking about it. I would become so nauseated, and it's because of all the pain that I was experiencing. I'm like, if someone touches me down there, like I could lose it. I could like really lose it. And so then I had to start grounding myself and realize, you know what, I need to be in control of that. I need to be the one who touches myself first, who starts to explore that, to start to self-stimulate and see what feels good and what doesn't, and then invite my partner into that experience. So just because 6 weeks might be that space where they say, okay, you're clear, it doesn't mean that you emotionally or you and your body feels that way. So being able to check in with yourself, being able to check in with your partner, maybe you're ready to go prior to that 6 weeks, whatever that looks like, know that you as an individual are experiencing something that's unique to yourself. That is going to be different than what your partner wants, is going to be different than what society is saying that you should do. Be in check with that and ask for help, because that's a key piece to all of this, that you were never meant to do this alone.
Thank you. Okay, so after reproductive age is our next subject. And it's really important for our consultants to be aware that menopause, it can happen naturally, or because of cancer treatment, which we will discuss in a bit, or even because of surgery. So, Dr. Evans, All of us are familiar with the typical symptoms of hot flashes and night sweats during menopause. And yet so many women grapple with what is normal during menopause because they're experiencing symptoms that aren't widely discussed. Shameful. What are some of the other symptoms of menopause? And is there such a thing as normal during menopause?
Yeah, thank you. So menopause is one of my favorite topics because pretty much 70% of my patients are in the process or have already gone through menopause. There is no particular normal of menopause per se, but there is a process to it. And there are things that are definitely abnormal. So if you think about it, it's similar to your crazy life change during puberty, but the opposite direction. So what happens in our bodies is that the ovaries start to have a decrease in reserves. Now this is natural menopause, not surgical menopause. So your ovaries start to have a decrease in reserves, and that basically just means that they're not functioning as well. Because of that, then your brain decides to overcompensate and makes different hormones that cause huge fluctuations in your day-to-day hormones, which leads to things like night sweats, hot flashes, changes in mood, all of that sort of thing. So when you think about menopause, you have to think about the emotional toll and then also the physical toll. So from an emotional standpoint, these changes can cause you to, just totally love everybody 1 second and then, try to rip somebody's head off like 2 seconds later. And that's very normal and it happens a lot. And I think that, and I'm sure Emma will cover this, it's very important that everybody else around you also is aware that this is just kind of part of the process. Also depression, very, very common, complaints are somewhere between 25 to 50% of onset of depression during and after menopause. From a physical toll, you have things that happen to the whole body, but then you also have things that happen to the pelvic floor, the vagina, and the ovaries. So from the whole body standpoint, you have the hot flashes, okay? So crazy hormones going up and down, so all of a sudden you just want to take all your clothes off and run into a dressing room, right? Then you also have the night sweats. And that generally, almost everybody will have a hot flash or night sweats at some point, but it generally lasts less than 5 years, so there usually is an endpoint in sight. But there is an unfortunate 6% of people where it will be lifetime, you're just gonna have hot flashes. And I'm sorry if anybody's out there that's one of those. But the night sweats are also very similar. You don't have night sweats throughout your entire life most of the time. The pelvic floor issues can be a little bit more complex, and that's something that I deal with on a daily basis. So after you lose your estrogen, you have a lot of different changes that happen to the physiology of the pelvic floor and the vagina. One of the things that happens is that the vagina has a ton of estrogen receptors in it, and it loves estrogen. The vagina wants estrogen to be there all the time, and honestly, so does the bladder. So as that goes away, we see an increase in things like overactive bladder, where you have to run to the bathroom every 10 minutes, you don't feel like you're emptying your bladder, sometimes you don't make it there in time. And then also prolapse. So those babies that you had that were so awesome and wonderful and we got all that oxytocin, well, you might still have the oxytocin, but your uterus is now dropping down, okay? Or your bladder's coming down, or because of that episiotomy, now you have a bulge in your rectum. So we deal with a lot of that sort of thing. When the estrogen goes away as well, the tissue inside the vagina changes significantly. So it goes from this nice thick tissue with great blood supply, lots of folds the way a vagina is supposed to have, stretchy, to basically looking like scar tissue under a microscope. Okay, and that's where everybody on this panel comes into play, because that can cause pain with intercourse, it can cause a lot of dryness, and then it can also cause emotional distress, because you want to have sex with your partner, and now you're just afraid that it's going to hurt so bad that you're trying to actively avoid it. So all of those things are within the normal realm, but there is no you're 50, you're going to go through it right now. Some people go through it when they're 40. Some people have a hysterectomy with their ovaries out at 35, and then it's instant. So there's no particular normal of when it's supposed to happen and in which order those symptoms might happen. But the good news is that everybody on this panel deals with parts of those changes that are uncomfortable and annoying. And so it's a multimodal type of way to treat things.
Aren't you guys glad you're here? I told you they're amazing. Dr. Novicki, as a pelvic floor therapist, I'm sure you see many women in your practice struggling with some of these symptoms. What symptoms can pelvic floor therapists address?
Well, obviously the physical therapist is going to deal with the physical aspects of menopause. As Janelle said, or Dr. Evans said, the dryness is a major issue, which can cause discomfort during intercourse. Some of the products that you have to suggest to your clients are the lubricants, the Just Like Me, the Euphoria, that are water-based lubricants that are pH balanced. Suggesting that to decrease the friction that might occur during intercourse can reduce the discomfort and the muscle spasms. Obviously, many of these products are interchangeable throughout the lifespan. If weakness is an issue, you have your Benoit balls and your exerciser balls. And that's really important during menopause. With that loss of elasticity, what kind of holds your organs up against gravity are ligaments that are on the inside, and then you have your pelvic floor muscle underneath. So if this is your bladder and these are your ligaments, if your muscles are weak, good old gravity wants to sag them. Well, now there's nothing underneath that bladder supporting it, and good old gravity again wants to put it down to the ground. So as it's doing that, it's stretching those ligaments, and over time, you can have issues like incontinence. So if we can help those ligaments out and develop that support in the pelvic floor, we can help those bladder and bowel and sexual function occur more normally. So again, using the exercise tools. Another thing, we have found that orgasm is very beneficial in terms of improving circulation, improving lubrication, improving pelvic floor muscle tone. But if the vagina is dry and you're having issues with that, it may be too uncomfortable to have vaginal orgasm. You can recommend to your clients that a clitoral orgasm might be more comfortable. By using the clitoral orgasm tools that you have, the stimulators, they can actually allow themselves to experience an orgasm and all the health benefits of an orgasm without the discomfort of having a vaginal penetration. One other thing, we realize that the pelvic floor doesn't work alone. It's connected directly to actually hip muscles. It's connected to your spine, it's connected to your abdominals. All the things that we did when we were younger might result in arthritis and chronic injury later on. And so if you're experiencing anything that has pain, if it's connected, like say you have hip pain, and you have muscle spasm due to that, that can affect your pelvic floor. So we not only treat your pelvic floor directly, but we also are treating everything that's connected to it. It's not unusual that when you have pelvic floor spasm that you also have deep hip stabilizer spasm. So we'll teach our patients how to relieve that spasm in the hips or in the back or in the abdominal muscles. And one of the things that you can recommend to your clients are the heart massager. It's a little bit too warm to really feel good down there, but it's great, especially in the hips and in the back, that allows them to get a little TLC at home, as well as improve their health too.
Thank you. Emma, Can you help us understand how sex therapists can help with the unique challenges that menopause presents for couples? We're also really focused on women's sexual health in our conversation this morning, but I have to tell you, a lot of our consultants are asked how men's sexual health, how it challenges them. Can you tell us a little bit about both?
Yeah, so typically when I see a couple in my office who are going through menopause or who are perimenopausal, they're starting to experience some of the symptoms, we'll hear about headaches, low libido, being up all night, not being able to sleep, being agitated or irritable. And so they're coming in and they're saying, things are on a downhill spiral, what do we do, right? And my favorite thing is that now we're going to start to get into the nitty-gritty pieces of your relationship, which I really enjoy. So with the low libido piece, there are sex hormones, right, that start to decrease your libido. But what I think is really important with libido has to actually do with connection, right? So your hormones can start to decrease, but if you can start to be in tune with your partner and start to hear them, start to see them, they can start to see and hear you, then we're on a different conversation. Now that you're in my office, you're experiencing menopause, you're confused, we're able to open up that conversation for how do we want to start to experience sex now? How do we want to start to experience intimacy now? You might be experiencing pain, so I want to help you see a sex medicine doctor, do some physical therapy, and at the same time, I want to help you challenge your idea of what sex looks like. We are told that sex is penis gets hard, goes into the vagina, and then there's an orgasm, right? But now we know about sexual fluidity, there's a lot of different types of relationships out there, and if we can break away from this equation that a hard penis and a vagina orgasm equals sex, then we're able to open ourselves up to what Esther Perel calls the art of sex. We're able to get creative and we're able to explore and experience so many more aspects of our body and our partner than we might have been doing prior to menopause. So really menopause can be good, I think, because it opens the dialogue up for, well, what else is there? How do we start to connect in a different way? Brene Brown says that the way to get to intimacy is by being vulnerable. Intimacy is knowing and being known. If I can know my partner, know what they like, if they can really know me and know, you know what, sex at 9 p.m. now isn't going to work for me because I'm tired and I'm asleep. Really, sex after 9 p.m. after like 25 doesn't work for most people, if we're being honest. So if we can start to have a dialogue, when does sex work for us? You know, if that's not going to be our time, which is also a societal message, like you have sex at night, how do we start to talk about, well, when does sex work for us? When do I feel most desire? When do I feel most aroused? How do I want to be initiated sexually? What does that look like? Oh, we've been doing it wrong. We haven't had this conversation for 20 years, but you've been wanting this other thing. How do we start to open that up? So to be vulnerable means to open yourself up to being known by your partner, which is incredibly challenging, right? And Brene says that the reason why we don't want to be vulnerable is because there's two areas that it could lead us. We could be vulnerable and our partner could reject us and say, I don't want to be a part of any of that. You want that strange stuff over here? Mm-mm. So we hold ourselves back from even risking talking about that vulnerable space. The other part of vulnerability is that if we're open and we say, hey, I would like to do this thing over here, or I've been having this fantasy about you, what do you think? And they say, oh gosh, yeah, I'm totally on board with that. Then it opens us up to more intimacy and we're able to go deeper with each other. So really menopause can help provide a gateway into being known by our partner because we're being forced to have this conversation with our partner in a deeper way. For men, what we see is that as you start to reach 50 and then after, we'll start to see that erections aren't as erect or hard as we might have seen before. You might not encounter an erect penis just by thinking about your partner. It might be more flaccid or not hard, and so you need more play. Orgasms aren't as strong. You might be experiencing an orgasm and ejaculation in a flaccid state, so the penis isn't erect and it still can have it can still achieve orgasm and ejaculation in that flaccid state. Men's testosterone starts to decrease, so what we find is that as testosterone decreases, we also see an increase in depression just because that hormone, that's part of what that does. And so we start to see a decrease in testosterone, increase in depressive symptoms, so your partner might not have the libido that he once had. And what we find is that if you're in a what we call cisgender heterosexual relationship, or if you have same-sex attraction, the partner who has the low libido, the other partner starts to feel like, what am I doing wrong? What's wrong with me? Are they cheating? Are they having an affair? Are they going outside of the relationship if like that's a concern of yours? But really it can be about the hormones. It can be nothing about you. It could really be about more of the hormonal piece that's happening. So just like with women, men also experience societal pressure of, if I don't have that erect penis, if I'm not able to last a certain amount of time, then I'm failing. I'm not able to have that sexual satisfying relationship, and so my anxiety increases. If I go in and I'm not able to achieve that thing that I'm supposed to be doing, my manly duty, then who am I in the world? And it can really affect one's identity. So being able to sit with a man and hear what he's having to say, hear his challenges, and then encourage that challenging what is sex and what is sexuality and what is sexual performance, letting that go and starting to open up that sex is art piece, and how can we explore different things? How can we slow everything down, which is the beauty of it, right? How can I experience more of the sexual experience versus just penis, vagina, orgasm? Same with men, like as with women, how do we slow everything down and start to explore more and get rid of this idea of the equational sex piece?
Dr. Bartlett, what is GSM and how can hormones and lasers help?
Okay, GSM is a fancy word. A few years back, they decided to come up with, the experts, a term that includes all of the vulvovaginal changes that occur with menopause. So it's genitourinary syndrome of menopause. So vulva, vagina, bladder, that whole neighborhood and all of the stuff that happens. Dr. Evans had sort of suggested that as the estrogen goes down, as you get further into menopause, the hormone changes then affect anatomic changes. So dryness, pain with sex, a lack of elasticity, things feel tight, there's a tearing, a burning sensation, more prolapse, more urinary tract infections, all of that. And most women experience it to some degree the further they get into menopause. It is extremely common. So first thing is identifying it. All the time I see women in for their regular exam, and I sort of have to ask these questions because a lot of times women aren't bringing it up until I ask. And then when I ask, sometimes it's met with tears. I haven't had sex in 5 years. Well, why not? Because it hurts, and now he thinks I don't want him, and it snowballs, and it becomes a huge problem, which is why we all work together, because it's not just one small issue, it's complex. So these hormone changes then cause anatomic changes, but we can absolutely correct them. We can certainly stop the progression and oftentimes reverse them if addressed properly. So for some women choose to take full body hormone therapy. So that's estrogen pills, patches, creams, whatever. And that's to address a number of different estrogen needs. And to some degree, that addresses the vaginal needs. Most women, even if they don't want or need full body estrogen, most of those women can still have and still benefit from vaginal estrogen. So we are huge advocates of the different preparations of vaginal estrogen. It is very safe, it is very effective, and there's a lot of different kinds that we can customize for your needs. What becomes interesting is you got to kind of back it off, because most women would prefer to try the simplest thing first and then do kind of a stepwise approach. So we tell women lubricants. Almost everybody needs to use a good lubricant, preferably one of these. There's all different kinds out there. Some are better than others. Some actually cause more harm than good. So in my office, we give out samples of these. We also give out a handout that explains why some are better at different phases of life and why some are better or worse, depending upon what's going on with you anatomically. Even in young women, though, sometimes the lubricant just is not enough. A moisturizer is something that you use for everyday use, just generally feeling discomfort. You're sitting around in your yoga pants and things don't feel quite right. That's a very common scenario, and so we use lubricants, we use moisturizers. And then when those fail, which oftentimes they're just not sufficient, that's when we add in a form of vaginal estrogen. And as I suggested, there's a lot of different forms. It's just, you have to have a conversation with your doctor about what's out there. And we're actually at an interesting time right now where finally women's health care is getting attention and women's sexual health care is getting attention. So there are new products, and some of them are affordable, and insurance is covering them and recognizing that this is a real problem, that is a medical problem. So I would underscore, talk to your doctor and talk to your doctor about more than just one solution. We take it a step further then. There's this vaginal laser that people are starting to talk a lot about. We talk a great deal about it in our practices. The vaginal laser, I say that in the sense that it is a technological advance. It is the same type of lasers that women have used for a long time for their skin to sort of renew their face, increase their collagen, increase the vascularity. So women have used it for aesthetic purposes for a while. Now we're starting to use it for medical purposes in a very different part of the body. So there's a few different kinds of lasers that are commercially available. So some of your doctors may have them, some may not, but they're pretty common. So most busy cities have a laser somewhere. It's just a different kind. So we both do laser therapy. We have two competitor brands, but the end result is the same. So oftentimes we use it. Some of it is on label, some of it is off. It has been cleared by the FDA, so we know they're safe. There just isn't tremendous long-term data to say what it's really capable of doing. We oftentimes use it for dryness and pain with sex and those symptoms I talked about with the genitourinary symptoms of menopause. Now, there's some additional studies. In my office, we just completed a study where we looked at lichen sclerosis, a very, very common dermatologic condition. It happens on the vulva, and it is severe and significant and really affects sexual function. It has not been approved for that purpose. That's why we're doing studies and actively trying to offer additional treatments to women. So there's a lot of that out there, and it's something that you're going to hear more about, and I think it is extremely promising. We're just actively engaging and making it more mainstream. Hopefully by making it more mainstream and having more data to support it, then suddenly we can get insurance to cover it. I think that's important, is right now it is cost prohibitive for a lot of women, and that's unfortunate. That will change in time. It's just a slow process of proving that it works, proving that it's probably cost effective over the course of many years, and then getting insurances to recognize that. So we're sort of in the process of that.
Okay, this is a fun one. Ready? Dr. Evans, Dr. Bartlett. If you watch Bravo, which we talked about this morning in the green room.
Patty does.
I watch Bravo. It's my guilty pleasure. You watch E, or you attend a pure romance party. There's always someone talking about vaginal rejuvenation. What are they talking about?
Yeah, so vaginal rejuvenation is a dirty word in my opinion.
You saw us all cringe for a second.
Yeah.
The language is misleading. Right?
Yeah.
Oh, there's a story to come.
Exactly. So back in the day, a couple of decades ago, there were a couple of urogynecologists that came up with the term vaginal rejuvenation. Their brand of this was convincing doctors to come into their little ORs and offices and learn this method where you reshape the vulva for an aesthetic purpose, okay? It has no medical purpose whatsoever, because they said that, the vagina is supposed to look a certain way, right? Like your labia are supposed to be exactly perfect and symmetrical and all of this stuff, which is ridiculous. But that was what vaginal rejuvenation was about 20 years ago, up until the lasers came around. And what happened with that, and it's completely the laser company's fault, they basically started billing themselves as vaginal rejuvenation. And that's a big problem, because all of our societies, so the American Urogynecologic Society, College of Obstetrics and Gynecology, everybody pretty much says this is not a recommended thing to do. You should not, for no reason, have your vagina altered because you don't think it looks good enough. And if you want to look up, and I always tell everybody, I was going to bring my coffee mug with this on it today, but if you want to look up the vast variety of what the vulva and the labia are supposed to look like, you go to wallofvaginas.com. It is this massive piece of art, this European artist came up with it, massive piece of art where they basically did plaster casting of thousands of vaginas, okay? Thousands of vulvas, and they put them all next to each other on the walls. So I have a coffee mug that has the wall of vaginas on it. And so does my partner.
You do.
Yeah. My partner does too, which is a little awkward because he's a big dude and he's like sipping out of his wall of vaginas mug. But yeah. But so,
It's not
you know.
at Starbucks.
No, it doesn't. Yeah, you can't get it at Starbucks, but you should.
Specialty item.
Yeah. But yeah, so all vaginas are created differently. All vulvas look different. All labias are different size, and it's fine for them to be asymmetrical. The laser companies decided to put themselves into that category, which is a problem because you're going from something that is plastics, it's aesthetic, to something that is supposed to be treating genitourinary syndrome of menopause. So an actual medical thing that people need treatment for. And so that's why I can't stand the term, and I'm really angry with the CEO of Mona Lisa because that was the person who like started it off and basically said, ooh, come get our vaginal rejuvenation, and even said it on the website, and it's just not what it's about.
So that really does hurt when women need it for insurance purposes, right?
Yeah.
Because it's a luxury.
Yes.
It
Yeah.
blurs the lines, and I think it discredits us as women in a way. Now, we have another expert that we were talking with recently, and she made an interesting point that there are situations where one labia is significantly larger than the other, and it causes significant body image issues. It may be the result of trauma, it may be how you're made, but there are situations where there are things like that that we correct based on the conversation with the patient, based on their desired goals. There's a lot involved in that. So that is not uncommon, but I never use the term vaginal rejuvenation because I'm trying to correct a perceived flaw, not make them look 21 again, and not make them look uniformly like porn. And I think that's a problem is people watch porn and everybody looks the same, but that's not how normal women look. So there's a little bit of a distinction between something that you find feels and looks abnormal, you need to talk to your doctor about, and that may be something correctable if you desire that. But rarely is it something you have to correct. There's nothing wrong with you, and rejuvenation is just not the right road to go.
Love it. Dr. Evans, many of our consultants work with cancer survivors, and it's more than likely that we have cancer survivors in this room today. That's awesome. Can you give us a little more insight and education on medically induced menopause and the challenges these patients face?
So cancer is life-changing in so many ways. Obviously there's an emotional toll. You realize your mortality all of a sudden, depending on what age you are, whether it's in your 20s or in your 80s, you're just like, oh, I have something that could really end my life, right, in most cases. That, from an emotional toll, I'll let Emma talk about that a little bit more, but requires a lot of consideration. But the emotional toll is, we talk about that a little bit more, and the physical toll is the part that we don't mention as much. So there is both medically induced and surgically induced menopause. And I'm going to start with surgically because I think that every gynecologist and urogynecologist office, anybody who's taking out a uterus and ovaries, they need to have somebody available that's similar to Emma or any sort of a psychology-based person to discuss all the things that are going to happen afterwards. When you have your ovaries taken out, it's instant. It is instant menopause. Maybe you'll feel good for 24 hours, but then all of a sudden, all of those changes that are supposed to happen over a course of 10 years, they happen all at once. Then you're also dealing with issues with chemotherapy sometimes radiation. So that's a huge problem. And I think there's far too many people, and I think it's starting to change now, but there are far too many physicians back in the day that did not mention that at all to you when they said, hey, you're 50. You know what? You're going to go through menopause anyway, so why don't we just take your ovaries out now, right? We'll prevent something. Or you have ovarian cancer, you have to get them taken out, right? But nobody discusses the emotional and the physical toll that it's going to have afterwards. All of that genital urinary syndrome of menopause, it's almost instant. Some people will notice it over a period of 10 years. You just had your ovaries out, it's gonna happen in 6 months to a year, And so you went from having, great sex and, good lubrication to having a lot of pain and being afraid of having intercourse. The medically induced part of things is also very important. Some chemotherapies can cause early onset menopause, and so that's really important for people to know that if you're gonna go through chemotherapy, you probably should also talk to somebody about, hey, what are my options for the menopausal symptoms because of my particular type of cancer? After breast cancer specifically, it is recommended for a lot of people to take medication for anywhere from 5 to 10 years and sometimes even life that decrease whatever estrogen reserve you have left. And that's because there are a lot of estrogen receptor positive breast cancers out there. Now, when you take that, you get, it's kind of like, having your ovaries taken out. It's very, very similar process where all of a sudden you're going to have the hot flashes, you're going to have the night sweats, you're going to have, genital urinary syndrome of menopause and, thinning of the vaginal lining and all of this sort of stuff. And people don't talk about that very much either. But like Dr. Bartlett was saying, there actually are quite a few different therapies that we can do for all of this. Some things are fine if you've just had chemo or just had your ovaries out. Some things are not indicated if you've had radiation. So for example, the lasers currently are not approved for people who have had pelvic radiation. So if you had cervical cancer and you had to have radiation, if you had fairly progressive endometrial cancer and you had to have radiation, you can't use the laser for that. But there are different things such as lubricants, hormones, all of that we can use to help.
Dr. Nowicki, can you talk us through your work with cancer patients and some of our products that might help improve symptoms?
Yes. So in breast cancer, radiation surgery may leave you with head and neck issues, shoulder issues. You might not be able to move it as freely. You may have lost some strength. So obviously physical therapy can help restore that back to normal. If you have lymphedema after treatment, there's certified lymphedema physical therapists that can help you to reduce that lymphedema, teach you the proper way to do things that will not exacerbate it. In gynecological cancers, where there might be radiation to the pelvis, oftentimes that leaves that vaginal and the bladder and the bowel as well fragile, possibly stiff, and with muscle spasm and pain. So a pelvic floor physical therapist can help you restore that to be more normally functioning. Some of the things we have already talked about with the myofascial release techniques, we would utilize for that as well. One of the things that we utilize absolutely with this problem is the dilator set. The dilator set is a wonderful tool, and there's many different dilators out there, and as we talked about before, The nice thing about this is that it is graduated. So, you can start out with something much more tolerated and just gradually move up and be able to tolerate vaginal penetration. We utilize these dilators, we just don't send you home and tell you to just insert it. There's very specific techniques that we can show the woman how to improve the elasticity and reduce the muscle spasm utilizing these tools. The other dilators out there oftentimes are very hard and very scary. They're cold when you go to use them. They're not very comfortable, whereas these they're silicone, so they have some give to them. Women like them because they stay warm, they don't get cold. They also hold on to that lubricant a little better than the hard ones that you might get just, on Amazon. Also, with pelvic radiation, and particularly if they're having any of that treatment due to colon and rectal cancers, the rectum and the anus are very important for bowel movements, possibly anal intercourse, and that area needs to function as well as any other area in our pelvis. I understand this is kind of a new product, the anal beads, but
just introduced last night.
Oh, very good.
So they're going to love hearing about this.
You can see that it's smaller than, obviously, some of the dilators. But what's nice too is that our bowels, when we move, the stool moves along. It's not. It's oftentimes, bumpy. So by utilizing something like this, that they can kind of simulate some of that natural in and out motion of the bowel, which is important for normal functioning. The vibration part of it, again, can be used to desensitize, improve circulation, improve the myofascial qualities of the anus. I do want to encourage you to not be intimidated to seek out talking to any pelvic floor therapists that are in your area. You know your products. You know when there's new things that come out, and we're always looking for things to help our patients do what we need them to do at home. We can't see them 3 times a week. They've got to do this at home. So don't be intimidated. Let them know that you're out there and what products that you have. We can take a look at it and know what we need to have happen, and you can help us know what we need to do to help our patients keep getting better. If they don't know of anybody, I'm assuming you could help them geographically find somebody too, right?
Absolutely.
I imagine some of you don't know where to start with that, but she could probably help you with that.
Absolutely, yes.
I wanted to mention
therapy is good for men too.
Yes.
Yeah.
Yes.
Will you show me the yellow? Will you hold that up? I had a patient just last week, and it just broke my heart. She has a lot of perianal involvement from the lack of estrogen and some skin disorder, and she's seen some different kinds of providers, and the advice she got repeatedly was to use a Sharpie with a glove. We have better options, and people deserve better, so it's good for you guys. You need to be informed that there are better options and informed that there are providers willing to think outside the box and really try to help these patients. So I think it's a critical thing for you all. You're in an interesting place as friends and as consultants and advisors to be able to direct patients to when you can help them and when they need something more, and who can be compassionate and open-minded to give them something more.
And I also will say that I recommend this dilator set specifically to a lot of my post-op patients. I do a lot of joint cases with the oncologists at my hospital, and I almost always just hand them the card and say, hey,
This is what you're going to need to get afterwards. Wait 6 weeks because you got to heal and there's stitches and all of that. But, this is what you're going to need afterwards because things are going to change and you're going to need to do a little bit of dilation. Then I send them to physical therapy as well. So.
I'm so glad years ago that we developed those dilators. It just warms my heart. Thank you. Emma, so many of these couples struggle with feeling alone during and after cancer treatment. How can a sex therapist help these couples navigate fear and depression and ultimately regain intimacy again?
Yeah. Cancer's scary, right? Going through cancer, after cancer, finding out your diagnosis. When I'm sitting with clients who are experiencing cancer or in remission, one of the things that comes up is that fear, right? Is feeling like now that we're out of this phase, we are completely different people. We're a completely different couple, and we're not sure how to even engage with each other. During the cancer process, what can happen is that you're just surviving. You are in this place of just trying to survive potentially, right? Your partner might feel like, I don't want to do anything that's going to hurt them. I don't want to do anything that's going to disrupt them. I just want to keep the peace for them. And so there starts to become this new dynamic that happens where the overarching piece becomes cancer. Your identity starts to feel like I am cancer, right? Your partner starts to feel like our relationship is cancer. And we lose the relationship piece of that. We lose the intimacy in that. Rightfully so when you're really sick too. So in that process, how do we still prioritize each other? Not having sex has never killed anyone. No one's ever died from not having sex, right? But intimacy is vitally important for the foundation of a relationship. So if we say, you know what, I'm sick right now, my partner sees that I'm sick, what else can we do? Maybe sex is off the table for a little bit. How do we still have intimacy? That might be physical intimacy. Intimacy is a lot of different layers, that knowing and being known, right? So how do we sit down maybe for 30 minutes every day and just ask each other, how are you doing? What's going on in your day? What fears are coming up for you today? How are you experiencing our relationship? How do we just sit there and know each other in that space? Maybe it's the physical piece where we say, sex is off the table. What else can we do? Can we hug each other every day? Can we have a cuddle session? Can we hold hands? Can we kiss each other? Can we have makeout sessions? What do we do instead then if that physical intimacy, if that physical sexual intimacy is off the table? What else can we do to still feel connected during that time? How can we talk to each other? How can we reach out for other people who are also going through this? I know the Cancer Family Center has different options for community around sexual health too. And so reaching out to people who've gone through this before, what did you all do? Finding out what's going to be helpful. When fear comes up, fear is the root of anxiety. So anxiety is, I'm worried about the future. I'm worrying about the future, right? Which we have no control over. Our minds can spin and spin and spin, and we can get exhausted by it because our minds are thinking about, well, what can I do that's going to help me survive? How can I stay in control? And ultimately, fear starts to take over. But if I can surrender myself and say, there's literally nothing I can do about this except for, going to the appointments and just being, how can I then surrender myself and say, ask fear questions? Why do I fear? What's coming up around fear? What's coming up around depression? What's coming up around anxiety? If I can almost see it as a human and just ask it questions, be present with it, and then allow myself to be in the moment of what is going on right now. If I'm present in the now, I can see all of you all, I can engage all of my senses. So what do I hear, smell, feel, touch? So right now I can feel the table. I can feel that it's got some grooves in it. I can smell the air. It doesn't really smell like anything. I can see you all. I can hear myself over the microphone. I'm present right now. I'm not in my mind.
So if I can allow myself to be present in the moment and engage with what's in my environment, I can start to surrender to some of that fear and just know that the only thing I can do is be here now. That's all I have is right here now. And that can then help alleviate some of that fear. Let yourself be, just give yourself some space from it, but don't run away from whatever you're experiencing. Ask it questions, be curious about it, but then also know, like, how can I live in the now, right now? With your partner, I think what can be helpful after, when you're in remission, is then identifying, so now what? Where are we at? Things have changed. Where do we go from here? Having those conversations, having those intimate conversations, being really vulnerable. I don't feel comfortable in my body anymore. It feels foreign to me. Engaging in that conversation first is really important. And then doing things like what's called sensate focus. So I'm getting to know my body. How do I explore my body? How do I feel what it feels like now? Do my breasts have sensation anymore? If not, what is that like for me? What is it like to go over the scars? What is it like to experience my vulva again? Is there vaginal dryness? Has there been any kind of surgery that's happened? How do I explore that area and start to lean into acceptance that my body just survived? I just survived this. How do I invite my partner into that to explore that too? So sensate focus is an exploration exercise where you lay down for 15 minutes without talking, and your partner just explores you through touch. So it's not a massage, and it's not caressing, it's not petting. You're not a pet, right? You don't want your partner to just, unless that's your thing. So, I don't know, maybe that's your thing. But your partner's exploring you. So if my partner was exploring me, I might say, he might say, wow, you have calluses, you're a badass, you try and do CrossFit every morning. that's my own thing about myself. What does the wedding ring mean to me? What does that symbolize? Like, okay, I didn't know that she had a freckle there, that's interesting. Or, wow, yeah, she doesn't have nipples anymore. What comes up for me around that? Or, what is happening? And as I'm being touched, I start to feel, what does it feel like to be explored? Am I anxious? Am I nervous what he's thinking? Am I out of my body? Am I allowing myself to really feel the sensations? Or am I in my head? And as he's exploring, maybe the sensations have changed, right? I don't have any nerve endings in certain areas anymore. What's cool about the body is that we have 3 layers with what are called the erogenous zones. One area is like your nose, where you don't really have much sensation there. Other areas, like erogenous zone 2, would be like your neck, your stomach area, your inner thighs have more nerve endings. And then genital touch, breasts would be typically your 3rd erogenous zone. But if you've lost that 3rd erogenous zone sensation and nerve endings, what's cool is that other parts of your body increase in nerve endings. So we can find that, for instance, there was a client who could stimulate this part of their body because the sensations increased, and they were able to have an orgasm through other areas of their body. So being able to explore, being able to be in tune with what areas actually are more heightened now in sensation, and how do I start to get to know my body in a new way with my partner.
Love you guys. You're so amazing. Amazing. Pelvic floor pain. I know we've been discussing pain throughout our conversation, but I want to take a moment to just briefly touch on some of the specific kinds of pelvic pain. Dr. Evans, Dr. Bartlett, what are some of the common cause of pelvic pain with clients, and what may they complain about? What medical therapies are useful for pelvic pain?
So we both deal with a lot of different causes of pelvic pain. The first Sexual Health Matters talk that we did, I actually brought my prop, which was basically 3 pages front and back of all of the different causes of pelvic pain. So it really is that extensive. What you have to know is that everything down there is
in the same neighborhood, okay? So when somebody comes in complaining of a type of pelvic pain, there's a lot of different things that you need to explore and very, very detailed exam that you have to do to figure out what kind of pelvic pain am I dealing with. Now, because I'm a urogynecologist, I'm going to talk a little bit more about the bladder and bowel stuff. So bladder pain. Bladder pain can be there for a lot of different reasons. Bladder pain can be there because you have a stone, right? And that'll pass, unfortunately, really painfully. The bladder pain can be there because of a urinary tract infection, right? But not all bladder pain is a urinary tract infection, and that is one thing that, you go see your primary care doc. And this is not to knock on primary care docs at all, but more often than not, they're seeing 1,000 people a day. You go in, you say, I got bladder pain, and then they give you some antibiotics, so they just assume you have a UTI. Well, that's not necessarily the case, and there are a lot of other things that can cause bladder pain. One of the most common things that I see is IC. So IC is interstitial cystitis. It is a chronic inflammatory disease that is probably autoimmune related. We don't totally know exactly why it happens. The theory behind it is that you had some sort of a traumatic event like a urinary tract infection or instrumentation of the bladder at one point, and it wears off a little hole on the inside of the protective lining of the bladder. So the bladder has a protective lining that keeps you from being in pain every time urine hits it. These people come in and their bladders are very, very small. They have to pee every 15 minutes. They never feel like they empty. As the bladder fills, it's very, very painful. Sometimes people are even so much in pain that they get nauseous when their bladder is filling. And so that's something that I see a lot in the office. Now, the good thing is that if you find the right person, we have this huge bag of tricks that we can try to help deal with some of the chronic pain. And some of it is referred to Kathleen, and some of it to Emma as well, so it's definitely multidisciplinary. But there are tons of medications, there are bladder installations, all sorts of things that we can do for that. The other thing is irritable bowel syndrome, and they all kind of go together. So irritable bowel syndrome, again, we have no idea why some people have IBS and some people don't. But when you have bowel problems, they can cause a lot of horrible crampy pelvic pain. And so that's another thing where we would work with the GI docs to try to figure out what's a good medication regimen, do we need to do some physical therapy on top of that, dietary changes, all of that sort of stuff. And then pelvic floor spasm. So I would say I do about 10 what we call trigger point injections a week in my office for pelvic floor spasm. We do that in conjunction, usually, with our pelvic floor physical therapist. But basically what it is you have this big bowl of muscles, and what Kathleen was talking about earlier. Huge bowl of muscles, and they support everything. They're supposed to hold up the urethra, the vagina, the uterus, the rectum, right? What happens for a variety of different reasons, usually something traumatic related, like you just had surgery or you just had a baby, something like that, is that the middle part of those pelvic floor muscles go into spasm. And it's not like, I got a knot in my shoulder, so I'm gonna rub it out, like it's totally different than that. It's generally described as super sore, a lot of pelvic pressure, sometimes feeling like you're being stabbed in the vagina, and pretty much makes sex near impossible. And so between putting injections into those muscles, which sounds awful, and it's not particularly fun, but it really, really helps. It's a combination of an anesthetic and steroids to get things to settle down, and then off to physical therapy so that you can do the dilator therapies and things more comfortably. So those are the most common things that I see in my office.
So as a regular gynecologist, I can tell you it's interesting because pelvic pain is such a big topic and it deserves a lot of time and attention. And like we mentioned, I always tell patients, well, your ovaries are in the same zip code as your intestines and your bladder, so somebody's got to take some time to sort it out. I mention it this way because it should not be this is my pap, this is my breast exam, and oh, by the way, I'm having pelvic pain. It deserves much more than that. Do your PAP next week. Talk to them about the pelvic pain because it does deserve a longer, more comprehensive visit. And unfortunately, healthcare in the traditional setting is high volume and in and out, and so your doctors might seem annoyed when you have anything other than just your PAP to talk about, but make another visit because it's worth talking about. And pelvic pain is just one of those many topics. So what I see most commonly are fibroids, which are benign tumors of the uterus. They're almost always benign, but they can be large and they can have a lot of problems. I see ovarian cysts. A lot of times women will come in and say, oh, it's my ovary. I've got something wrong with my ovary. There's a lot of parts around the ovary, so it may not be your ovary, but we'll look at that. Ovarian cysts are very common, oftentimes benign, but painful, and there's things we can do. Endometriosis is super common. It is also underdiagnosed because I think it's really easy to say, oh, you have bad periods, go on birth control, it'll get better. Maybe, but there may be a lot more to that too. So that's the kind of situation where you have to advocate to keep having that conversation and making appointments to keep talking about that. So we do ultrasounds, we do CAT scans, we do targeted physical exams. There's birth control pills, there's hormone therapies. We both do a ton of surgery, so you can imagine this isn't a quick, easy 5-minute office visit, but it deserves more.
Emma, Dr. Nowicki, is there anything you want to add on what you do to help with physical?
And I'm not sure if we'll be talking about the chronic pain aspect of it, but that essentially is the main thing with, besides doing all the things that we had talked about, physical therapy also deals with helping somebody get out of the chronic pain situation, where the alarm system is overactive. When you have pain, the natural thing is for the body to protect that area. And in terms of pelvic floor, there's a tension that goes on and a spasm. It's a very protective mechanism. This part of our body is very essential to our species. You know, it's what keeps us, reproducing. So it's very connected to that autonomic nervous system. Then it has that two sets to it, the fight or flight response or the relaxation response. And when there's pain, the body wants to do one or the other. It wants to get away from it or it wants to fight it off. What happens in the pelvic floor is it tenses. It tenses because you've got to have stability to do one or the other. But if the pain is right there, obviously it's going to tense because it's trying to protect that area. Over time, that's no different than an athlete who trains every day to get ready to run a race. As soon as that gun goes off, their body's ready. Unfortunately, that's what happens with chronic pain, is that your body gets more and more efficient at going into that spasm. So part of what pelvic floor therapy does is it uses different tools. One of it is biofeedback, because again, this is an area you can't really see, but it allows you to see it because you see your activity of your muscle on a screen, and we can show you specific things that, oh, if I do this, I can bring that tension down, and it doesn't hurt me to do that. And then we make it a little bit more challenging, so that eventually you're re-educating your nervous system to say, oh, I can do this, and look, nothing bad's gonna happen to me. And the alarm system starts to go away slowly and slowly, and your function gets better and better. So that's what we do.
Yeah, so our brain is our biggest sex organ, right? So if I'm going throughout the day and I'm starting to think about, oh, I'm gonna have sex with my husband or my partner or whoever tonight, and I don't want to, and I'm nervous because there's been pain before, I start to unconsciously squeeze that pelvic floor muscle, whether it's your butt, your lower, like your core area, your pelvic floor. So if you think about it right now, I always do this exercise. You let me know if this is wrong. So this is your pelvic floor. It's like a hammock. So if you think about This is what I do with clients. Squeezing up a bowel movement, if you do it right now, because nobody's watching you, you can feel like the bowel movement being sucked up, right? And if you like push out like you're having a bowel movement, you can feel that. Well, okay, let's squeeze back up. And you trace that down to your vulva, your vaginal canal, your urethra. Can you feel that squeezing up motion, movement? And you can push down. That's your pelvic floor muscle that you feel. So if I'm thinking, oh gosh, I don't want to have sex tonight, if I can start to be aware of, is my muscle tight or is it heavy, which is what Kathleen would work with you on, it allows me to start to become aware, what we call progressive muscle relaxation. It helps me become aware of my muscle down there. Is it tense right now? How can I help it become more like heavy and restful, which Kathleen would do exercises on with you. But that's really helpful in terms of cognitively, the way that the mind starts to interact with the body subconsciously. So if we're more aware of our body-mind connection, it can be incredibly helpful. So for pain, if you're in a sexual situation, what I do with couples is we identify how do we get back to a place where we can start to engage in a sexual situation again. So I have them go through that sensate focus like I was talking about when we were talking about cancer, except we do it a little bit differently. I'll have the client lay there, they're doing the sensate focus where they're exploring the body, but I have the person who's being explored think about what's coming up for me, what anxiety is coming up for me, what images or memories are coming up for me. And they don't do anything sexual, they're just exploring, and then they talk to each other. What was that like? How do I start to move out of that space and start to notice my partner as being a safe person, that trusted person? How do I get out of my head and back into my body, doing that being present stuff again? What do I feel? What do I hear? What can I touch? What do I feel like in the bed right now? If I can get back into my body, I can start to feel the sensations again and start to allow for that arousal and that desire to take place. So we'll do some inner thigh work where the client's being touched on their inner thigh. We'll have them being touched on their vulva. And what we want to do is to be able to decrease that anxiety, decrease that fear, but in a way where they're experiencing it without a sexual situation happening, and be able to process that with their partner. And then when they feel more comfortable, then we go into that more vulva penetration or touching experience. If they're doing dilators, I encourage them to start doing it with their partner. There's a huge fear to overcome when there's sexual pain and then insertion again. So what I'll have them do is I'll have them do the dilators with their partners, with them in the room or in the area, and then once they feel comfortable with that, then I have the partner engage in that. So this could be sessions, like the first session would be, or the first few sessions, them getting comfortable with the dilator and their partner being in the same room. And then engaging in that. So the partner then inserting the dilators with them and starting to do more things like foreplay and making out. What is it like to have something inserted while we are engaged in more erotic touch and getting that arousal. So arousal is your body feeling that desire, even though your body can be aroused without being having desire. So incorporating the dilators into the relationship, starting to merge back into safety or having safety with your partner can be huge. And then if other things come up like sexual abuse or being violated in the past, we want to be able to explore that first before we then dive more heavily into the sensate focus and integrating your partner.
I want to add to that really quickly. There are still people giving the advice out there that, oh, you have pain with sex, just have a glass of wine. We still hear this. Yeah. And it's grossly inadequate and offensive. So there are better tools. We all have many better tools. But an interesting sort of corollary to that is we do use vaginal Valium. And it's not to knock you out and make you not care. It's vaginally applied, and it is sometimes a missing tool to allow those muscles to relax, to then let your brain do what it's supposed to do and let the rest of your body fall into place, to utilize the tools they're offering. So that's one example, but there are medical things we can do to facilitate this whole body process, and it's way better than a glass of wine. So.
Thank you. Now you see why they all work well together, right? It's just not one, it's a team. It's a whole team. All right, so we're looking at the time down here. I want to give them at least 15 minutes, so we're going to move through these really, really quick. But I think that these questions, so we're going to talk about what's on the horizon. So, Dr. Bartlett, let's start with you. What is hypoactive sexual desire disorder, and is there a treatment that is available for this?
Okay, we talk about low libido all the time. Lots of reasons, lots of explanations. HSDD, hypoactive sexual desire disorder, is a very specific term. It's low libido that has to have gone on for at least 6 months, so it's chronic, it is medical, it is treatable. There's a lot of different things that contribute to this libido thing. So when women come in with complaints of libido, I give them this pie chart to look at. For men, it's blood flow. Viagra works because you give them increased blood flow, they're great. For women, it's hormonal status, medication side effects, trauma, pain. How do I feel about my body? How do I feel about my partner? We have a kid 3 feet away knocking on the door. We haven't had date night in 2 months. That's a big pie with a lot of pieces. So that's why it's been difficult to find one drug to fix all of that, and there isn't. But there are medicines that can make a dent in some of the physiologic and chemical things. I don't know if you want me to go into some of that. There is a role for testosterone, and a lot of doctors who are familiar with it and have experience with it do use it. Men need testosterone, women need testosterone. We just need about 1/10 the amount of men, so it's a little tricky. You have to have experience in how to do it properly and safely, but that is an option. Until now, there has been one sexual health medicine for women. It's called Addyi. It's a medicine you take every day, and it works on brain chemistry. It works similar to like an antidepressant, where you don't take it when you feel down, you take it every day so that your lows are a little lower or a little higher, and evens out some of that. It's the same idea. You take it every day, so when the circumstances are right, you are more receptive to that sexual activity. So that is currently available, and there's lots of gynecologists able and willing to give it, and we should. There is a second female sexual health drug that has been approved by the FDA, and it should be on the market next month. It is the only true as needed. So like a Viagra, you take it Saturday night because you know Saturday night you're going out. This kind of medicine is going to work like that, where you take it when needed rather than every day. So that is very soon, very closely on the horizon. And then there's hormone therapies and other things, but those are kind of the big ones.
Just put this in perspective, girls. So we're soon to have 2, and men have 26. Am I correct?
Mm-hmm. And that second one just happened. That 26.
Yeah, not on
forever,
the market yet. Yeah.
Forever. We're getting there. We're getting there slowly, but we are getting there.
This is why we push forward constantly as women. We want to make sure that we're being addressed. Am I right? All right, Emma. When I look through magazines and scroll through Facebook, I see the O-Shot advertised over and over again. What is this thing called an O-Shot?
Yeah. So Dr. Charles Reynolds, who was the inventor of the O-Shot, approached me about 6 years ago about being on his team and wanted to show me what this was, what this thing was. And so it's a plasma-enriched platelet-enriched plasma. I don't know the doctor piece. Basically, what happens is they take your blood, they spin it around, and then they inject it back into your vagina and your clitoris. And it's supposed to enhance orgasms. He called it the vampire facelift for your vagina. If you know the vampire facelift, it's the same technique, but for your vagina and your clitoris. So what we've seen then study-wise is that there just isn't enough studies to inform us on the efficacy of it. ACOG, which is the board certifying for gynecology, even says that because it's untested, they don't recommend it, that they would say that it's unsafe because of the lack of research out there currently. So right now, that's kind of what we have in terms of O-Shot. But what's good is that there are other things out there which you have if you're a part of Pure Romance. And that is that one of the top ways for anorgasmia, which is the lack of orgasm, whether with a partner or by yourself, is using a vibrator. So we technically don't need the O shot. We just need you to help these people. Right? Yes. There are other things out there like OMGYes. Do you guys know OMGYes? Yes. So it's a website you should go to help the people that you're working with, and it's a site where they can go in and learn different touch for themselves to know how to experience self-pleasure, to know how to experience orgasm, like edging, where you increase your arousal and then you back off and do something else and then come back to it. There are other areas and other ways that you can experience orgasm. So OMGYes, check out OMGYes. Just put yourself in front of them and then help them know how to use a vibrator, and it'll be good.
Awesome.
Yeah.
Dr. Evans, is there anything in the clinical trial pipeline that our consultants should be aware of?
Yeah, so I did an extra search yesterday just to make sure I wasn't missing anything. And I went on clinicaltrials.gov and CenterWatch and all of these other things that talk about things coming down the pipeline. I put in several different search terms, including sexual dysfunction. There are 78 trials going on right now that are for sexual dysfunction specifically. The bad news of that is that 55 of them are for men. So we're getting there. It's not like 2 to 26. It's like, we have 2/3 of, they get 2/3, we get 1/3, right? Part of the issue is that we are really far behind for a variety of different reasons, like what Dr. Bartlett was saying about the fact that sexual dysfunction for women is a much more complex thing than just blood flow. But also because this wasn't taken seriously. Erections make money, right? They make a lot of money. And we weren't really considered in that process until more recently. So we're playing a game of catch up. What I did find in the literature that is coming down the pipeline is that there are a couple of drugs that are similar to Vyleesi, the one that's coming out in September, that are not injectable. So this one in September, you have to inject it, which is kind of a bummer. But then again, it's pretty easy to get used to injecting yourself with things, right? I don't know. Anybody done fertility treatment? Yeah. So they're not injectables, they're pills. The trials are currently out of Germany. So obviously the Europeans will get it first, and then we can decide whether or not the FDA is going to be able to approve that. So there are a couple of medications. What I thought was a little bit disconcerting, but also good at the same time, is that there are a bunch of different trials that are evaluating what happens when we take more than one of the treatments that we already have and we put them together. Okay, so like for example, there's a medication called Intrarosa, and it's a vaginal insert, and what you do is use that with the laser. So there's a trial coming down the pipeline to see whether or not does that improve your symptoms of pelvic pain and genital urinary syndrome and menopause more than just the laser, more than just a vaginal cream or a vaginal pill or a pellet or whatever. So there are things like that going around. There's also a couple of trials on different antidepressants and how to make them more tolerable and also decrease the sexual dysfunction associated with them. And then also very interesting, so I do a lot of sling surgeries, okay? So basically you cough and you pee your pants, I fix that. So the majority of the time, if physical therapy does not solve the problem, we put in a little device called a mid-urethral sling, okay? And what it is it goes underneath the middle part of the urethra, hence the name, where you used to have great ligaments that held the urethra up, and every time you would cough, they would squeeze to the side and close the urethra so you wouldn't pee. What the sling does is that it replaces the function of those ligaments, right? But the other problem is that it's right near the nerve bundle that we call the G-spot more commonly. So if you make too big of an incision when you're doing a sling, you're directly disrupting all of those nerves. So there are several studies going on showing how do you figure out, where does that nerve bundle start? I mean, we all know it's right underneath the bladder neck, so about 3 centimeters in.
But where does it start? Where does it end? How much can you cut when safely not damage anything? So there are a couple of anatomic studies going on like that. So things are catching up. It's just kind of a slow process, and the guys are still getting more of the attention.
Awesome. All right, we have 2 microphones on both sides of the room. For those of you who have questions, and I'm sure that you do, you can start lining up. One of the things that I want to say is that when you go to your physician, many times you only have, insurance purpose-wise, you only have about 10 minutes. The thing that I love the most about Sexual Health Matters is these physicians are here to really give their time, really inform us on newest and latest treatments and why. And then now the opportunity to ask questions. I hope that you have loved this as much as I love it. So we're going to let the questions start on this side of the room.
Hi. I have a patient or a client who has had her ovaries taken out and her hysterectomy previously because of cancer, and she had previously gone through menopause, but her concern now is odor and how she might possibly taste during oral sex. So I was wondering, is that something you've come across before with patients? Okay.
Yeah, so that's all part of the genitourinary syndrome of menopause. Okay, so think about how when your tissue changes, the way that your tissue reacts is also going to change as well. So nice young vaginas that are really nice and thick, when you look at them under a microscope, lots of folds, good lubrication, all of that, changes to very, very thin, not as great blood supply. The skin cells slough off more, and that's what causes the funky discharge after menopause, and also sometimes odor. And it also sometimes causes a little bit more incontinence. And so you're dealing with odor from the cells, you're dealing with odor from a little bit of urine, all of those things. Hormone therapies are pretty much our first line for those sorts of things, and different types of compounded creams to put what you need back into the vagina. You need a little bit of estrogen, sometimes you need that moisturizer, lubrication, all of that. And for the most part, you can decrease that feeling like you have something wrong going on down there, like you have a funky discharge, you don't smell good. If it's a urine problem, definitely come and see somebody who can help with that, okay? Because there are lots of urogynecologists pretty much everywhere in the country now. And really, I mean, that's what we do. Overactive bladder, stress incontinence, overflow, not being able to pee, all of that sort of stuff, so.
I wanted to make the statement that hormones are not all bad, and most experts think they're pretty good more times than not. And there is a distinction between whole body hormones and vaginal estrogen, and vaginal hormones are safe for almost everybody, even some cancer survivors. So that certainly also merits a much deeper conversation. Don't just rule it out and say this is just the way it has to be. That is not the case.
Awesome. This side?
Hi, thank you for the panel. It was amazing. My question goes more to Emma or any other who wants to answer it. Many women who go through full mastectomy, most of them go to reconstruction, right? But recently talking to my doctor, she has told me that many have embraced not the fact that they have to put implants again, just loving the body the way is after a full mastectomy, right? How would you handle that in the intimate part of the relationship, not having the breast, which sometimes is something very hard for the male partner or the partner in general? Maybe someone who doesn't want to put themselves through surgery again to put the implants, just embracing their body the way they are. And
Yeah, so I had one client recently who said, I've been through so many surgeries, I can't put myself through another surgery just for cosmetic purposes when I don't know that that's necessarily what I want. And so I just do a lot of, we have to, in our society, we're inundated with what we're supposed to look like and be like, that it starts to become part of our identity. And so what I do is I sit with a client, we start challenging those messages, we start challenging why we think that way, why we feel that way. And it's difficult when our partner might want something different, but being able to have that conversation and being curious. So a good listening technique is when your partner is talking or when you're talking to your partner, having them be curious around what you're saying, empathetic and validating so that you feel really heard and known in that situation. But I think it's amazing, whatever you want to do, it's your body, and being able to feel comfortable with that and letting your partner come along that journey with you, even though they might have a different idea. Having that conversation and healing and growing in that space together of self-acceptance, I think is really important, but you're having to really challenge yourself from what culture is telling us and society is telling us too.
Awesome. This side?
Hi, I just wanted to ask, I get a lot of women at parties speaking about prolapse, vaginally and anally, and I'm just wondering what you would recommend in terms of, are the Benoit balls still appropriate for someone to use who's experienced a vaginal prolapse, or if there's something better we can sort of recommend they go to?
So vaginal prolapse is really common. So 1 in 7 women will have prolapse that needs to be addressed at some point in their life, so it's super common. So I would expect that all of you would eventually see somebody or have a client that needed a product but they didn't know if it was safe. The great thing about prolapse, if there has to be a great thing, is that it is not life-threatening, which is awesome. And it's generally very safe to use dilators, it's safe to use vibrators, any sort of a dildo, you can use any of that as long as you're comfortable doing it. And some people are and some people aren't. From a how do you fix it standpoint, well that's, if they're like, hey, I want to get rid of this prolapse, it's bothering me now, that's when you come to see somebody like myself. Other than that though, if they're comfortable, just use whatever you want, but lots of lubrication, lots of lube.
If I could just say something about that. If you're using the Benoit balls and you have a prolapse, obviously if you try to progress to utilizing them in the standing position, they may fall out. But they're weighted, so and they're still giving proprioception, so it can be done in a laying down position or in a semi-reclining position.
I just wanted to say thank you, but also to ask if it was possible for a list to be created maybe by all of you that could be posted somewhere so that not only we as women, but we can share with our clients to interview our healthcare providers so we can find somebody that has the same mentality that you ladies do.
Thank you. I agree.
And I think there's some of that on pattybrisbenfoundation.org. I think there's a list that started, but of course, like wherever you are in your area, being able to reach out to identify who to contact.
But also, I mean, if you want a cheat sheet of like a little note card to say like, okay, this is what I'm experiencing, we can easily do that. That would be super easy to do. But also, if you go to this website, so it's IUGA, IUGA.org, there is a patient resource button on there where it is basically patient information about every sort of pelvic pain, pelvic prolapse, incontinence, sexual dysfunction, libido issues, all of that. Is mesh safe or not? I just wrote that one. So all of that is on that site, and they're really good, like 3-page pamphlets that are really easy to read with good pictures. So
I want to point out too that a lot of you guys and a lot of your clients have great doctors. They're just in practices and part of American healthcare where women's health, women's sexual health is not a priority, so they just don't have time for it. So if you were able to carve out large enough visits, if you were able to come in there with targeted questions and requesting, I would like to see a specialist for this because I recognize this office maybe doesn't do it. Self-advocacy is huge, and then we can certainly help direct you to other people.
Thank you. Over here.
Could you tell me a little bit more of what I should expect being diagnosed with PCOS?
I see it every day. It is super, super common, and it is underdiagnosed, kind of like endometriosis, because sometimes doctors will say, oh, you just need to lose weight and take birth control pills, and it is way more than that. So there's a whole spectrum. I tell patients, if you were to Google it, you're going to see people who look thin and healthy and seem perfectly normal and have no real period problems, and then you're going to see really extreme problems hormonally that cause acne and hair and weight, and then everything in between. So it is a metabolic problem, it is a hormone problem, but it is a very manageable problem, and there are a lot of tools, but it's a complex thing. It's not part of your wham bam pap. So if you're having irregular periods, if you're having infertility, weight problems, acne, hair growth, you need to talk to your doctor, and you need to talk about all of that so that hopefully they put those pieces together and say, you know what, this might be more than just any one of those issues. It's very treatable.
And once I have a client that I'm like, oh, hey, I think you have PCOS, we've gone through the route of diagnosis, you start them on the things that you know that they're going to need. But I also send everybody to an infertility specialist, so reproductive endocrinology and infertility, mainly because you're diagnosed usually pretty early. I mean, if you're going to get diagnosed, you're usually diagnosed in your 20s, usually. And those infertility specialists can do a lot more of little tweaking of different symptoms so that you don't have to worry as much about fertility really being an issue with PCO.
This time?
Hi. So people with vaginas can face pelvic floor issues as they age. Is that something that people should be aware of for like rectal and bowel issues? Will those also get weakened as they age? And also, can we as consultants offer the dilator set for backdoor use? Is that corporate endorsed?
Do you want to do that one?
So I can talk a little bit about that. Absolutely. I'm sorry. Absolutely. The tissues in the rectal area are no different than the tissues in the vaginal area. They can become dry and fragile as well. In the case of using dilators rectally, we recommend, as far as in my practice, that we encourage them to use the dilator set, actually. Because it is useful with that progression. Most of the time, if it's more of a bowel movement issue, they're not getting pretty much further than this or this, because a bowel usually isn't that much larger than that. Obviously, if anal intercourse is something that is desired, then possibly we might encourage the ability to tolerate a larger dilator if indeed the partner is larger. It is different than vaginal tissue, so I do recommend that they do work with a pelvic floor physical therapist when you're doing any anal therapy with the dilators. It is more fragile, so it can break down more easily, and the tissue very quickly goes from muscle to bowel, versus vaginally you have a much more rigid type of tissue. Definitely it's something that we do, but if it is something that is medical, I suggest that they see a pelvic floor therapist to help them with that.
Yeah, and not only that, so the weakening of muscles or the over-tightening of muscles is only part of the picture. If you're all of a sudden having bowel problems, it can be a lot of other things too. You could have prolapse and not know it. A lot of people don't know it until I tell them that they have it, and hey, this makes sense why you can't poop anymore, right? Other things that can happen is actual problems with the nerves within the bowel. And so before recommending something like the dilators, I think it's really important to have that fully evaluated because you don't want to do more damage than good.
So let me speak corporately. So with our dilators, we're not handing out recommendations for how to use the dilator. We expect the physicians to tell the client, tell the patient exactly how to use it and what size to use. So we just have these here. So that's not, most of the women that are going to purchase these are patients that their doctors have recommended them to go buy them. And the reason that Pure Romance went into the business of making these dilators is because so many women couldn't afford them. And they were so expensive. And we went into the business of doing this because insurance was not covering them, so we could provide them for the physicians and for the patients that needed these. So I leave that in the doctor's corner on how to use these. Make sense? Okay.
Before going through biofeedback, would you ever prescribe or suggest patients to use medications like sedatives to help with pelvic pain or spasms? If you do, how long should a patient take these medications to avoid dryness issues?
So sedatives, not so much. Valium, like Dr. Bartlett was saying, vaginal Valium does have pretty decent evidence. There are also certain compounded creams that we tend to give to patients that are having chronic pelvic pain that eventually will be going through physical therapy that have anything from a medication called gabapentin, which is a nerve modulator. Sometimes they have steroids in them. Sometimes they have estrogen in them. Sometimes they have all of the above and Ativan. So it's a very complex issue, but I would say sedatives and opiates, not the way to go. That's not the path you want to go down because, like we were saying before, pain is extraordinarily complex, and when your body gets used to pain, it starts to compensate, and then there's more pain, and then there's more pain. So it's really important to deal with the issue without over-medicating.
Here.
Good morning. What is the best lubricant for our customers who are trying to get pregnant?
Patty?
I would definitely recommend Just Like Me.
I would say anything that's water-based.
Yeah.
Don't use anything oily. I mean, I've had so many people come in and they're like, my doctor told me to use Vaseline. Don't use Vaseline, please. You're gonna get yeast infections and stuff. It's not good. Pure Romance makes a ton of great water-based products. Some pH, some not so much. Different, some of them are very liquidy, some of them are a little bit more thick. So it's really personal preference. I don't think that there's one versus another that really would promote pregnancy versus not.
So what she's saying is keep your patients away from things like the sensations when they're trying to conceive. So use like the Just Like Me. All right, over here.
Yes, I was wondering if you could recommend some resources for people that suffer from hidradenitis suppurativa. I know it's not a gynecological disease, but that's the first place people will go.
Oh gosh, I see it all the time. All the
gynecologic
time because
disease,
we're doing breast exams and it oftentimes affects the breast, the axilla, and the groin. So I diagnose it constantly and it also goes hand in hand with polycystic a lot, not always, but oftentimes. Dermatologists treat it, gynecologists treat it. You sort of have to figure out, is there a testosterone excess that's causing it? Antibiotics sometimes work at the localized level of inflammation. There's a lot of different treatments, but I do all the time see women who have really disfiguring scars in their groin and around their breasts, and I ask them, why do you have these scars? Oh, I get boils. That's more than just boils. So if you're somebody who is prone to that, you need to talk to either your gynecologist and or a dermatologist because that is very treatable.
This side.
Hi, I heard you mention very quickly Lynch's sclerosis and the vaginal rejuvenation. Could you please elaborate on that? Because I don't think we know enough about it to catch it before the damage has been done.
I think that's the biggest problem with lichen, because, or all of the complex of lichen diseases, is that I mean, I'm sure that Dr. Bartlett has the same thing. We get so many people that have probably had lichen for 10 years, and they've gone to see 3, 4 different people who have just taken a look and been like, little scarring, hard to see, you know. What it is it's essentially, it's another one of those, we think it's an autoimmune disease type of thing. It causes inflammation and scarring around the vaginal introitus and oftentimes also around the anus. That scarring can be so bad that it closes the vagina off. And it can be very disfiguring. It's extraordinarily painful. It's like it's progressive. And it takes basically your genital urinary syndrome of menopause symptoms and makes it like 10 times worse. You can have bleeding, you can get super infections, all of that sort of stuff. So if somebody goes and they get their estrogen cream and they're like, no, something's still really wrong, that's when they need to come in and get a biopsy to see, is this a lichen problem or is it not? But it's very common.
It's very common, and it's very easy for practitioners or whomever to assume it's just the lack of estrogen when it really is a step beyond that. It requires chronic steroid treatment, which can be very effective when done properly. There's about a 5% chance of it turning into skin cancer though, so you need to recognize it and do surveillance for that. And like we said, it is progressive, so when treated and addressed early, it's very fixable. Like I mentioned, we're presenting data coming up at a conference about the laser for use for it. So it is not used currently for it. It is experimental, but that is something I think we're going to see more of.
But we both use it in our office for specifically lichen too.
Okay, I hate to do this. We're going to take one last question, but for all of you that are in this line this morning, would you not say that this is the best panel of doctors? So, what they're going to do is you can send your questions to the Patty Brisben Foundation.org, submit those there, and what we'll do is we'll have this panel of doctors answer those questions, and we will have them submit it within the next 2 weeks. Does that sound fair? They didn't know they had to work after this, so sorry. Right here.
My question is, what would you recommend for someone who has been diagnosed with PCOS, but it may also be going through menopause?
It's interesting because PCOS gets better with menopause, so there's the upside. So you kind of exchange one set of problems for another one. But I think really talking to a doctor or an endocrinologist who, and then as a gynecologist, some of us do more endocrinology than others, sifting through which symptoms are attributable to the polycystic and can we manage those, and which symptoms are truly perimenopausal and can we manage those, and ease the transition from the one to the other, because it will get better, which is good.
Ladies, will you join me in giving these wonderful physicians, therapists a big round of applause? Thank you.